14 A's. Gave a couple extra points, but didn't necessarily need to. So really high scores, which is good. It will help a lot of people. But of course, the next thing in line is going to be the cardio test. So the cardio test, which of course is a 100-point test over this section, is next week. Again, you'll have 9 to 12, whatever we have it, if you need it, for 3 hours here. And that will really be the last test you have until after Thanksgiving, and then the last 2 weeks you have the lab test and the final test. Again, the final test is just on that last section. That'll start really after next week, so a couple weeks from now. What else? Hopefully, if not, it's up to you, but practice. The practice questions, I don't know how many people have looked at them, but they're critical, okay, to do it. Not only are they helping to work you through some of the things I know that are on the test and some of the language of the multiple choice questions, but there's information there on a couple questions that I didn't cover directly in class, but you're responsible for, okay, because I'm introducing it in those questions. So you need to do those questions, make sure you understand them. I will, today's lab isn't too bad, except we need to bleed you guys. Next 2 weeks we need your blood, just a couple drops, but it is a blood lab, so, but it's not that long overall, so again, once we're done with lab, you're either free to go, or I'll start reviewing, a lot of material in the test as well. The other aspect then too is just like I've tried to say, there's a lot of material on this test. It is a hard test, but I wanted to make it where this last week before doesn't have as much stuff. Okay, so you're going to see as I start to look at this a bit, all we have from that one PowerPoint is capillary exchange. So the big thing on this last PowerPoint again was the systemic blood pressure, which we'll kind of go back and make sure we can fill that in. That is your short answer, essay question, whatever you want to call it, is literally that chart that you're going to not only use to get those points, but as you start to see now, I hope, you're going to be able to use that to answer a lot of the multiple choice questions and kind of, do that as well. Local control we did, myogenic autoregulation, active hyperemia, reductive SERV, and then we sort of ended up with, the effects of epinephrine hormone. So the only other thing left in that, which I'll talk about in a couple of minutes, is talking about capillary exchange. That's that. Then the last chapter on blood, you're going to see, again, just like I did in neuromuscular, really, compared to the material we've had in the last couple of weeks, it's not going to be that much material. So even this shouldn't take most of the period. And then, we'll see what time it is, and then we'll see where we are. I can start reviewing. Probably do want to start reviewing a bit for everybody, but then, we'll move on. So, any questions coming in about anything? All right, so first of all, hopefully you've done this a few times by now. So let's actually go back and sort of make sure that we sort of have this. So let's skip over all this stuff. And really, the picture that I want is not just to show that, but it kind of helps to show this right now, at least, as we're starting to practice filling this in. And again, we're going to do this in a minute. But sort of what else do I have up here just to kind of get us, our brain starting to look at things, is I want to, again, make sure, besides these practice bombs, I'm going to have a lot on cardio drugs. Okay, we've already talked about a few of these. And again, when we're doing this, it is, if you've done the practice as well, you see I'm going to be looking for primary effects, alpha blocker, beta blocker, digitalis. What else do I want up here? Including atropine, which we're supposed to look up on your own, of the actual effects of it. But looking for primary effects and then secondary effects. When I'm talking about secondary effects in this case, we're really looking at how it's going to affect blood pressure, and then how we're going to compensate for it, okay, how the baroreceptor works. That's kind of what we're doing on these. When we get to the kidney, and I'll wear a different shirt, and this is my heart shirt, that some of you students forgive me, not you guys, but previous. Then we're gonna be talking about more than just a blood pressure secondary effect. We're gonna be talking about, effects of pH, effects of potassium levels and things like that. So right now, you're sort of reminding of that. The other major thing that I haven't specifically talked about, if you look at the first question of the practice exam, it's the idea of looking at sort of calcium channel blockers. And you can see, as you can imagine, now calcium is involved in almost everything we've talked about. So when you look at these calcium channel blockers, you're really going to be able to see how it affects those different ACT potentials. And we'll review those today in class too. The autorhythmic cells and the contractile cells, how that will affect that, and therefore maybe heart rate and blood pressure, force of contraction. Okay, remember, we will review it, but calcium is really important for the force of contraction. If you block it, less force, you go to the baroreceptor response. You see, everything's going to lead us to that. We're going to show a slide on how smooth muscles constrict. Calcium's going to be involved in that. Vasoconstriction, vasodilation, baroreceptor response. A lot of this test is leading toward the baroreceptor response. That's why, I want everybody to know it. It's the first thing you might want to put on your test. It is the only short answer, whatever you want to call it, question. And it really makes sure that you sort of can use this logic. Okay, so let's do this, and any participation would be appreciated. So, and when it comes down to this too, again, the baroreceptor, we can kind of see it up here, it does monitor blood pressure, and it doesn't just monitor if blood pressure drops. It monitors this if it's too high, it's going to do kind of the opposite of what we've been doing up here. Now, on the test, I'm not going to throw that at you, because you can see most of the things I'm talking about are things which lower the blood pressure and the baroreceptor response. That's what's going to happen. Okay, I'm not going to all of a sudden switch it. But if we were switching it, kind of everything would be reversed, right? If the blood pressure was too high, all these arrows, etc., would basically be the opposite way. So I don't want to give the impression that it's just low blood pressure. Baroreceptors will respond to both. But the chart you're going to do are the ones that we're doing over and over exactly, including abbreviations and arrows and things like that. You don't have to spell things out or write a paragraph when you see that question. You see that question? It is this. Okay, some people still won't believe me, and most people will do this. So again, almost everybody, if you've made it through this part of the course, I know you can do it, you're listening, almost everybody gets this question, right. And again, you leave with understanding, no matter, if you like my test or not. And again, just to kind of look at this, and we'll see why I have 5 columns or why I'm doing it this way, is again, once you have a blood pressure change, okay, which is obviously constant, right? It's going to be the baroreceptors located exactly where you might want them, coming out of the heart, going to the brain, goes to the control center of the brain, and again, here is where we have the autonomic nervous system come into play, sympathetic and para. And when we're talking about cardio now, sympathetic is the star, okay? Parasympathetic is only going to innervate SA nodes, only affect heart rate. But sympathetic has 4 branches here: heart rate, ventricular force, and then vasoconstriction for veins and arterioles. Okay, so that's why they are sort of the main one. When we do respiration coming up after break, we're going to see that bronchodilation, etc., and constriction, sympathetic is taking a break, so it's not going to be about. But right now it is. So this is, you don't have to draw all this for part of the essay question, but clearly it kind of helps us kind of get this overall. So let's see if we can do this. Again, any help would be appreciated. So, and we're going to see, I'll even add some things to kind of get that idea that anything that's going to create low blood pressure from what we're talking about today, you want to be thinking about the baroreceptor response when you're looking at these multiple choice questions, okay?
Thank you.
So, where are we here? And so, again, we have this chart to help us, where when we're talking about blood pressure, we have kind of 2 sides of it. How much we're putting in, which is cardiac output, and you definitely have to realize that cardiac output, heart rate times stroke volume, that's EDV minus ESV, which again is the end diastolic volume, which is what we put in, like say 160 mils, minus what is left after we contract, and that's going to be what we eject. Okay? And as we start to see, we start to have this idea that 5 columns, because all of these are controlling one another. The whole point of this is not to make our life confusing. It's the idea if one isn't quite working, we have another to compensate, etc. That's why I guess we're alive. So that's sort of the basis for this. So let's just use right now the example we gave, orthostatic hypotension. That's lowering blood pressure. So baroreceptor response will be to raise blood pressure. So again, you sort of see sympathetic, parasympathetic. And so this is the goal, who's going up? Sympathetic or para? Sympathetic goes up and para goes down. I do the columns, you could do a different order, but it doesn't seem to make sense to start changing it now. I sort of do these sort of, again, parasympathetic and then boom, 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 boom. It's all happening at the same time. You need to know the neurotransmitter and the receptor, because obviously we have alpha blockers, beta blockers. So I'll start with this one, and again, this is the one that kind of confuses people on the other question, but people memorize it here. But we are going to, again, decrease parasympathetic stimulation of the SA node. Okay, so parasympathetic, while it's doing all this, what is the neurotransmitter that parasympathetic is releasing? Acetylcholine. Now, importantly, okay, acetylcholine in the past is bound to nicotinic receptors called muscle and the addictive quality. Different receptor here. That's why it has a different effect. The receptor is muscarinic. And it's possible, by the way, like muscarinic, I don't even remember exactly. Some of these words, by the way, are probably in the multiple choice. And if you misspell this, but if you come pretty close, it's fine. Okay, this is not anatomy and I can't spell very well. So, but it can't be marla. It's got to have, you miss a letter or so, it's fine. Okay, muscarinic. And so let's just look what it does. When you decrease, okay, parasympathetic normally decreases heart rate, but we're inhibiting inhibitor. So if you decrease parasympathetic, the SA node, then you kind of go specifically, what does that affect?
Increases the heart rate.
What does it affect?
Increases the heart rate.
It's going to increase the heart rate, correct. And then you kind of go through the flow that we've been practicing with. If you increase heart rate, you're going to do what?
Increase cardio output.
And therefore,
Increase
blood pressure. That is exactly what I'm looking for. Increase heart rate, cardiac output, increase blood pressure. Everybody starts to follow that now. And again, if you start putting stroke volumes in it here or start reversing this, it's sort of not quite, not quite sure that you get it totally. And you might lose, some points here. But, it's basically to get this. Everything else is going to be sympathetic. And so we can actually, just to save time on this, sympathetic is going to go to all 4 of these places, but it is the same neurotransmitter, which is norepinephrine. Right now I'm just doing neurotransmitter. And again, for norepinephrine, all you have to write is NE. You don't have to have a legend or something. I know that, we've been doing this, you know what these are, and all these could be arrows and stuff like that. Believe me, if you write sentences or a paragraph, you're going way at number 30 when I'm writing, because I want to actually get through and kind of, just follow. It doesn't take that long to scan this. Okay, so again, I start on the heart. So now we're going to decrease sympathetic to the SA node. And let's just do on this. If you increase sympathetic SA node, what do?
Increase the heart rate.
And therefore?
Increase cardio output.
Therefore?
Increase blood pressure.
Everybody see that chart isn't something random now with this. It's sort of just following the pathway. Heart rate, cardiac output, and we've reached our goal. And we're sort of done with this segment here. Okay, when norepinephrine is binding to the heart, including SA node, what receptors?
Beta 1.
Beta 1.
Beta 1. Okay, important because we saw beta 2 are involved in for epinephrine. So beta 1, most beta blockers, in fact, any beta, when I say beta blocker on the test, all beta blockers we're using are specific for beta 1. If I say I'm going to do something with beta 2, I will say beta 2. In real life, there are some ones which can affect both, and if you look at a list of drugs, but my beta blockers are affecting beta 1. Okay, so we go to the ventricles. And so, again, so we're going to increase sympathetic to, the ventricular muscle. And again, if you just write that, vent muscle, I mean, I get it, okay? You don't have to spell out these things. Okay, and so what directly does that do to the muscle? Or what is it going to cause?
Contraction.
Greater force of contraction. Okay, anything like that word. So, because that's how muscles are affected. So greater force, contraction. So force of contraction. So now you want to get to sort of, again, this equation. If you end up missing one of these tiny things, you're not going to lose that many points, but I kind of want you to understand it. So if you increase force of contraction, which specific component here are you going to directly affect?
ESV.
ESV, right? If you force more out, that means, right, there's less left. Your end systolic volume is lower because you force, basically force more out. And therefore, you eject whatever, 130. So ESV is actually going down because you've ejected more. But really, let's get to the heart of the matter then. So what is that going to affect?
Increase stroke volume.
So it's going to
Increase
stroke volume, and therefore cardiac output, and therefore blood pressure.
blood pressure.
If you put heart rate in there, again, maybe not losing that many points, right? But you're not quite getting how everything is being separated and kind of used. So again, you're going to decrease ESP, that increases stroke volume, therefore cardiac output, and therefore blood pressure. Okay? All right, so we're done with the heart. Oh yeah.
What's the receptor?
Norepinephrine, yes.
Oh, the receptor.
Yeah, the receptor is beta 1.
Is
So
it
beta
beta?
1, yeah. Beta 1 are the two on the heart. Beta blockers are going to affect both the heart rate and the force of contraction. Okay? Again, whether you write increased ventricular force, force of contraction, anything like that, I kind of get, right? So it doesn't matter. Okay, now we go to the veins and the arterioles. And again, if you go back to this picture, since we're kind of reviewing, you kind of, in fact, I'm going to put a couple words up here. You kind of realize that these vessels we're dealing with, sort of these are, arteries or arteries versus the veins. They're both vessels, but they're basically have different function and structure. So when you look at our arteries, they are very elastic. They're like balloons. So when we basically pump blood in, and the valves close, it's going to push blood forward. So these are elastic. And again, the veins are like plastic baggies. Okay, so when you're entering that, like in a plastic bag, it doesn't, when you fill it, doesn't come back, it basically fills up. It's very compliant. We even put that word compliant. Kind of the opposite. So the idea that is that in the veins is kind of a reservoir. We don't want all the blood up here and the cardiac output going somewhere up, either blood pressure or going somewhere while you're kind of sitting around or sleeping. But when you need to, you want to get it up here. So we want to increase somehow venous return. And again, we'll go back to why a little bit later on this. But the idea is that sympathetic is going to be able to help that. So let's increase sympathetic. We're going to increase sympathetic to the veins.
Vasodilation.
So when norepinephrine are binding on the vessels, the veins and arterioles, are they using beta 1? Alpha. So alpha blockers are affecting this side of the coin. Whenever we're doing vessels, veins and arteries, the first thing you think of is that it's going to either affect vasoconstriction or vasodilation. Okay, so that's kind of the next one of this. So increasing sympathetic to the veins, what's it going to cause the veins to do?
Increased vasodilation.
Constrict. Okay, they're going to constrict. Calm down. That's the vasoconstriction. So that's why we're doing this. So vasoconstriction. Because what, again, we'll go back to that figure a little bit later, but the whole idea of that is, and you can just, I like thinking of the plastic bag idea. Even though it's constricting, it seems the opposite for venous return. We're constricting, but what you're doing is like a plastic bag. If you make it taut, the blood's not going to stay there, right? Already, the fluid's not going to stay. It's going to go further up. So literally, by just tightening that up, by vasoconstricting, that increases venous return. Kind of a clever system here. So, but again, it seemed opposite without that compliant thing. It seems like if you're narrowing this, how is that going to help? But it literally, you're making it taut, it will increase blood getting back up. Which means we're back here. This is the longest kind of one. So if we increase venous return, which specific thing is that affecting? EDV. Okay, we're putting more in. And so again, for that one, let's say you put in 170, because you've increased venous return. If we did both, you'd be up to 140. But idea, it increases EDV. Remember, the whole idea of this muscle, and we'll see later too, is the fact that if we put more in, here's my little rubber band, but your heart is basically kind of based by stretch receptors. So if you put more in, you're stretching it more. We'll mention in a minute that means more calcium comes in, but the idea is it's going to cause greater contraction. So you don't have to remember Frank's Starling law. You might want to remember it for keys or something if they're asking. But that's sort of this idea that a couple different ways to put it, but the blood returns or injects as much as comes in, but basically that's the idea. The more you put in, the more you'll pump out. And that's important. That's how we control a major control of blood pressure, and also cardiac output is the fact if we need more, we want that to happen. If we put more in, we know more is going to be ejected. So we increase EDV. What comes next on this little list then? If we increase EDV,
Increased stroke volume.
increase stroke volume. You can see now it kind of flows. Increase stroke volume, you increase.
Cardiac output.
And therefore,
Increased
and you're done.
blood pressure.
If you happen to just, mess up tiny ones of these, it's not going to matter that much for points, but I do sort of want you to leave kind of understanding the system. Now we're done with this side of the coin, but you can see why you got two things affecting heart rate. You have something specifically affecting EDV, something specifically affecting ESV. Kind of see the beauty of the system of how we have a lot of things covered. If one's not quite working, we can have the other one kick in. Okay, we do the last one. Now we're over here. PR represents peripheral resistance. You can just put PR when you're doing this. It's the idea of constricting, which increases resistance, or dilating, which decreases resistance. Allow more to go out. So, norepinephrine is binding to alpha, and we're increasing sympathetic to these arteries or arterioles, whatever you write. They are kind of the arterioles. That's sort of we're doing it. And whenever you're thinking again, that's going to cause vasoconstriction or vasodilation, and this one is
Constriction.
This one makes sense. Because if you constrict, what are you going to do to PR? The resistance here, if you make this tighter, increases peripheral resistance, and therefore
Increase blood pressure.
blood pressure. Don't be putting cardiac output or anything. This is all on that side of the coin. Okay? And so this exact thing, although you can, change these words slightly, on that thing, is full credit on that question. Okay? Nothing else. I'm not asking for, some people still don't believe it. I think by now maybe you believe what I'm saying on this. That's literally what the question.
Just because on the practice questions, you say describe in detail, like it's really important. It is okay to have the chart.
That is what I'm asking. That's why it's not clear when you just look at the words without, making sure you understand from what I'm saying here. Yeah, I mean, because this is detail.
Right.
But yeah, I
Not
understand.
paragraph.
I understand when you just read something like that, what does an instructor want, okay? I'm telling everyone here, that is exactly what I want. And in class, if you come up to me, is that okay? And in case you just are still don't trust me or unsure, I'm gonna be saying yes. Beginning of the next class, I'll be saying that. This is what I want, nothing else, okay? You put all this, you've got that question right, because as you start to see, well, you can practice a little today, that's gonna help you on when you go back to the multiple choice questions. And so everybody will have this in their head, put it down, boom, you have those points. Any questions about that? I'm gonna take a sip of my vitamin water. So we did maybe both of those before, but let's just again get that idea of when we're talking about even these drugs or anything else that we're looking for, and this will all be in multiple choice format, even though maybe the practice questions I was doing sort of open-ended. These are all multiple choice, but you want to be thinking of the primary effects, and which are involved in here, okay, for most of these drugs, and the idea of the secondary effects are the idea of compensatory effects. And this obviously relates to real life in the sense of you're being, you either are taking or being diagnosed to take these various cardio drugs, a lot of them for blood pressure, but then you're monitoring the effects on yourself, because I don't trust doctors anyway, are your patients of like, why are they having these reactions? And instead of just randomly saying, okay, I look up that these are the contraindications or the problems with some of these drugs, you will actually understand sort of why. It's kind of cool, right, to actually understand it. So, and this is a good one to use. So let's remind us on alpha blockers and how we would use this. Remember, this will be in multiple choice format. That's why you want to look at those practice questions, so you don't get confused on how to do it. Because we have enough writing on this. I don't like too much writing. Plus you got to take multiple choice tests anyway. So for an alpha blocker, we'll just write a couple of these things up here. So alpha blocker, obviously, the primary effect. Stuff like that. And so it is going to do what? Say it again. Vasodilation, yes. Vasodilation. Okay, of both of these. And then you're not writing all these anyway, but bottom line is when you do that, it's going to do what to blood pressure? Decrease blood pressure. That's alpha blockers are going to do. They open up both things, less comes back, less is out, or more is out. So that's the opposite. Boom. Okay, but as soon as you do this, I read it. As soon as you lower blood pressure, which is what the drug does, what is that going to trigger?
Increase the heart rate.
Well, that's not going to be a little slower there. But you are right. So you are going to have, as soon as this happens, and any of the things we're talking about, you're going to have a baroreceptor response, which means, and we'll put that bottom line here, but let's see what that actually means. That means, because you have to think about what might be on the multiple choice. The idea is it increases sympathetic and decreases para. Okay, that might just be one of the answers. I might not go to heart rate for that particular one, or I might have A and B. It's kind of a pain, right? But the idea is, if you see something like that, and you're like looking for that, you're like, okay, this is what happens. Okay, if you see a question, sympathetic para, you're like, okay, it is a baroreceptor response. I go to my back page. That's the right answer. Because the other one would be like lower sympathetic or whatever. But it does that, and then the whole idea, of course, is the drug wins. So you're not going to, even though you're going to compensate to try to raise blood pressure, ultimately your blood pressure is dropped. But, and the idea is, even though you have this more response, this still works, or else the drug is kind of crazy. You can't block this, but yes, so you guys sort of have it. This will still be stimulated, and you want to stop here, because again, some things, the drug is winning here, cardiac output, we don't really know all this. The big idea of you can stop is that it is going to increase heart rate, maybe to the extent of being called what? Tachycardia. And they actually call it, I didn't know all this. I mean, I'm not in the real world, but I'm looking it up and it's actually called like reflexive tachycardia because it is a reflex that's actually happening. I'm like, oh, that's cool. All right, we're just going to, the idea of tachycardia. And even, and that's probably bad, but even, increased force, you're putting a lot of strain on your heart.
So, you know how you said that maybe it won't go that far? It'll only stop like the baroreceptor response?
Wow.
Were you talking
No,
about?
No, I mean, when you're trying to look at like what the compensatory effects are, like they're here, you don't go like you can't say, well, it's going to increase cardiac output then, because that does the opposite, right? Because on this, remember, the drug wins, that's going to lower cardiac output. All of a sudden, you have this thing. So you really, but this still will happen. The drug wins everything else. So we're never going to say, how this affects us.
But like you said, sympathetic or parasympathetic would be one of the answers?
That could be on one of the questions. So notice, I might not even, if I do this, I might not even have this. I might have something like, well, A, it decreases heart rate. B, it decreases sympathetic. C, it increases sympathetic, or something else. And you're like, you're not seeing heart rate there, or it's like the wrong way, but you're like, oh yeah, well that's the baroreceptor response.
Should be C.
Yeah, be C.
Okay.
So you see that sort of way to look at these. That's why you have 2.5 hours or 3 hours. If you're unsure, you go back and see, that is true, and you go false.
Could you please explain what the 1 degree and 2 degree means again?
It's like the primary and secondary. Although and I've only, and remember the secondary, you can kind of think of, sometimes, tertiary, the idea that it's compensatory, right? It's compensating for what just happened. But that was only just my shorthand for that. And you can do the same, go ahead, sorry.
Oh, no. Okay, so you're you're blocking the alpha receptors, but why are we even looking at the beta receptor response? Because it's still norepinephrine. We're not looking at, and it's still in the heart? No.
Yes, right? The idea is, this is happening, so all of this is happening now. It's sympathetics going up, para's going down. I kind of ignore this right now. And the idea is, boom, norepinephrine is flying up. That could be the answer too, right? Increased norepinephrine. That's flying through the body, all those places. But the drug wins. So even though you're throwing more sympathetic, you're not affecting this basically because the drug is won, but you aren't blocking all this extra norepi going on to the heart. Okay, the drug doesn't block that, at least that drug doesn't. And that means, boom, all that is gonna go up.
Okay.
Does that make sense?
Yeah. What about acetyl?
Yeah, it will still do the same thing. I mean,
It's gonna increase.
it's gonna do this, right? So it is going to, and that's why it's gonna increase heart rate too. It's still gonna decrease. It's gonna have the same baroreceptor response. I just don't talk about that. Right?
So if you increase sympathetic, you're increasing norepinephrine, and if you decrease sympathetic, you're decreasing norepinephrine.
Right. But here we're always, on this point here, I'm always going to be sort of dealing with the increase because I'm going to be dealing with something that lowers blood pressure. Here, and I'll answer your question, here it lowers blood pressure directly. Now I'm talking about how a drug that was meant to lower blood pressure, because it lowers it, this will still happen, and you will have some sort of, on one or the other, a compensatory response. That could be within limits, and we're all cool, okay? But if it's not, then you kind of know, that's too much of the drug, the person's reacting too much. You have to do a different drug or a combo of it as well, and we'll see one. Yeah.
I think you sort of just answered it, but sorry if it sounds silly, but are all these like happening at once then? So if you're like increasing sympathetic, you're decreasing parasympathetic?
Exactly.
Okay.
Yeah, it's all this is happening at once. I've ignored when I'm talking about this, that, but you can see this is happening, so that's going to increase heart rate as well. It could matter for different drugs too, but yeah, all this is automatically happening. Yeah.
And this is only happening when it's when like it's hypotension?
No.
Because the goal is to increase
Yeah.
the blood pressure?
If it was the opposite,
Yeah.
everything would
will flip?
reverse.
But it does happen.
Yeah, exactly, yeah. And this is like, that's why your heart rate went up and down while you were breathing. Because this was responding to increase and decrease heart rate. So all this is happening both directions. But we're gonna
Are you gonna do that on the test?
No.
You gonna flip
Not
it?
in this, because this is like so important. Yeah, that'd be, I'd have to have a really like bad attitude that day or something. So, no. And usually my bad attitudes try not to affect students, so they affect everybody else, not my family, hopefully. But, okay, does that start to make sense? And now I'm not gonna do, you should be able to do beta block or alpha blocker, right? Yeah, did I do alpha blocker? You can be able to do beta blockers, it's the other half of the coin. We'll look at some of these other drugs, especially calcium channel blockers, specifically in class today. I'm gonna still wait on that. Okay, and if you look at the practice, and you'll see some of the wording of the multiple choice kind of idea too. But that is like why I said, I'm not gonna switch us on that, but it could just be, I might not be asking about this, I might just talk about this, or increasing norepinephrine, release or something like that. The answer, this has been vetted, let's say, pretty, a lot, so that, if you say, well, there's no right answer, or there's two right answers, and like, look again, okay? Because we've kind of gone over and over to make sure that those mistakes aren't there in case they were originally. So it will be here, most of them. Okay, so let's go into the new material. We finished the material part of the test, and at least part of it, and we might take a break in the middle, and then we'll start. What I really want to do, the first couple of questions on the practice, or whatever you want to call it, have to do with calcium channel blockers, and then kind of reviewing the things from the previous PowerPoint on remembering the action potentials that affect contraction and heart rate, etc. We're going to see calcium channel blockers kind of playing the whole role here, but we want to wait on that. So, but we will do it in class. I want to make sure of it. So, we get to the new stuff. Again, I'm just going to put these, I'm not going to review them right now. Again, the idea then, we did go to local control, and we just talked about myogenic autoregulation. Again, the idea that if you put more blood in, it automatically constricts. We'll tell you why. And you can review that, but not right now. And then the idea of this was protect, this is to serve, that if you have high metabolism, the idea these will vasodilate to basically deliver more. And so, we'll review that. But those two we did. Okay, then we did, those were sort of, I could take them out. But then we did kind of this, and I'm not going to review this right now, but we talked about then epinephrine, okay, which is like adrenaline, the hormone, and kind of how it worked with, the epinephrine, or the norepinephrine. I'm not going to review that right now, because we just did this. I'm going to come back to this without going crazy on all this. But I'm going to do that when we start talking about vasodilation, vasoconstriction. I'm going to really talk about how calcium's involved. But I'll do that when I'm doing calcium channel blockers. But don't get overwhelmed by all the things that are happening on that testing, all the middle things in the middle. It literally is going to be back to this. The more calcium comes in, the more contraction. But I'll get to that. This is our last thing I want to do. Capillary exchange. And we've kind of dealt with this early on and a couple times where we're even talking about the different compartments of water in the body, etc., like that. So now we're going to be talking about sort of the control, and what we're talking about is, we have fluid, in blood, right? So we have, the plasma that's going through, our blood system, and we also have interstitial fluid, right? So we kind of talked about that of, intercellular, but out of the extracellular, we sort of have what's in the blood, that fluid in the blood plasma, and what's in the interstitial fluid. You guys just did a problem with that. But so we're talking circulation, how is this going to be controlled? And there's two pressures which are up there. One is kind of the blood pressure within these vessels, right? It has pressure. And so again, we call this hydrostatic, but that's like blood pressure. So we have hydrostatic blood pressure. But the other one, as we're gonna see today too, has to do that besides, blood and, oxygen, carbon dioxide, et cetera, we're gonna have a lot of liver proteins that are being circulated. So the idea of, and I guess we just put liver proteins right here and point it. So liver proteins, which include things like albumin, and we'll talk a little about some of these in later today too, clotting factors, immune cells, but really looking at some of these, there's some others, these are proteins. So you're gonna have a lot of proteins here. In the interstitial fluid, the pressure is lower, there are no proteins. So we have two forces, okay? We have blood pressure, and now we have this idea of proteins being in one compartment and not the other, okay? And proteins can't cross, but water's out here and saying, proteins are here. That's like a protein party. Water always is attracted by osmosis to where there's more salt, protein, sugar. So that is what we're calling colloid osmotic pressure, okay? So we have the idea of colloid osmotic pressure is kind of a force to keep fluid in, okay? So this is colloid osmotic. I want to make sure that we get this in a second. Idea, since proteins are here, not there, there's that attractive force. Osmosis will basically push water, keep it out of here, and push it in this direction. But the opposing force is that hydrostatic pressure, or what we're calling blood pressure, that's higher than the pressure here. Again, it's, did we even put it? Yeah, I don't care about the interstitial pressure, but it's higher. So basically, this is pushing water in from the plasma, from the blood to the interstitial fluid. We have two opposing forces. Now, blood pressure is pretty high. These are sort of the veins. We get out of here to the arterioles, and arteries. The idea is veins is pretty high, and I don't think I had that picture, right, or I don't want to go back. Remember, pressure kept dropping. So pressure is much lower here than it was before it gets to the tissue, but the proteins are still here. They didn't go anywhere. But blood pressure has dropped. Everybody kind of remember that chart? It kind of went from high to low to low to low. Everybody? Yeah. So I don't need to put it again. So what this means is this. On the venous side, see the more green. On this side, as blood is flowing through up to the tissue, blood pressure beats osmotic pressure. And so there's a net flow of water out of the blood into the tissue compartment, the interstitial fluid, okay? Blood pressure wins. Blood pressure, colloid osmotic pressure is just not as high. And you can see you don't need the numbers, but like the difference is 10 millimeters of mercury. But the idea of pressure on this side is pushing fluid out of the blood into the interstitial. But we don't want just blood, water to fill up our tissue compartment. On the other side of the coin, blood pressure is dropped, but proteins are still there. So guess who's going to win now? That hydrostatic pressure, because of the proteins, can push most of the water back. So H2O on the arterial side flows back. So on the venous side, no, go ahead.
How come you keep saying decreased blood pressure, but the arrow's up?
Well, I tried to make it smaller. It just, see, do I have this? I didn't know exactly, because of this. It's like I didn't want the arrow to go down because blood, or pressure is still higher than this and higher than this. But, you know, overall, it's just osmotic 1. It kind of went from 32 to 15, it drops.
Okay.
But I didn't know exactly how to draw that very well. But yeah, that's a good question because it's kind of confusing. So that's just, that's why this is actually good, although you don't memorize the numbers. So here it's 32 and here it's just 15, so it's dropped. But this is still the same. So you can kind of just see by the math that, you know, this 32 beats 22 here, so boom, comes in. But because that pressure dropped and this stayed the same, water comes back. So this one wins here because the blood pressure is high. But when you get to this side, because blood pressure has dropped to this, boom, osmotic pressure, those proteins, that's why liver proteins are not just important for everything they do, just for the maintenance of pressure, you know, between tissue and blood is really important. Let me do you and then, yeah.
So the osmotic pressure stays the same because the amount of proteins are exactly the same, and the water goes to wherever the.
Exactly. Does that make sense? That's why I'm big on osmosis, and I seem crazy on osmosis. You know, it seems like, oh, it's some chemistry thing, because that determines everything. Okay, that's how, when we want water in a place, we can't say go, we, you know, or have like a little pump, we really have it, we move, or we have sugar or proteins, or ions on one side, and that will push the water. A question?
I'm just confused because on the slide it shows like the venous end has the little.
Oh, yeah, I made that wrong, sorry. Thank you. Yeah, well, I'd be confused too. Did you say arterial? Yeah, arterial. Yeah, thank you. Everybody start to see, you know, if this doesn't help, maybe this picture's actually better. Hard to see the difference here. So on this side, blood pressure wins over osmotic. Proteins are, these are liver, mostly liver proteins. Water's coming in. On the venous side, blood pressure has dropped. The proteins stay the same. Now this number wins. Water, most of the water comes back. To be honest, a little doesn't, but that's where it gets to. It ends up draining from the lymphatic system into the blood, and we're not doing much on the lymphatic. The bottom line is just remembering the idea of the two pressures. Okay, blood pressure winning on this side over osmotic, and losing on that side. I think it's time for liver failure. We could have some liver failure now. So, doing that, and that, and that. So for liver failure, I want you to work through a few things. Okay, we already know it's affecting protein in some way, okay? And that's going to affect something else, I kind of want, basically, when you look at liver failure, but I kind of want you to go through it, idea is, ultimately, how is that going to affect, you know, where H2O goes? And really then, how does that affect blood pressure? Okay, and you should start to see there's by now, so there's a linear order to things that we're sort of talking about. Okay, the first one obviously affecting proteins, okay, and how important they are. And so I want you, again, you might not know exactly these, we'll get them, but work out sort of systematically, you know, what's going to happen here if you have liver failure. I want you to do that again on your own-ish, or talk to people, so I'm not going to just write the answers down. So, go. Just start talking, or working on your own if you don't like people. Hey, what can I say?
of just kind of gonna say like the opposite, so like the pressure's gonna increase instead of decrease. Maybe that.
Yeah, I've got like there's gonna be too much protein in
Yeah.
there, so that's gonna have too much water,
Mm-hmm.
and then that's gonna increase the blood pressure, and then drop the heart rate. Did I go rogue on the heart rate?
I feel like in some way disconnect, but I don't know yet how it connects. If I'm being honest, this is like the one I feel like I can't take in any new information at the moment.
Well, I don't know if I went rogue or not.